Well, joining us to better understand this condition and its management is a consultant pediatrician, Dr. Ikechukwu Okongo. He joins us virtually. Hello, doctor. Good to have you join us today.
Hello, Perpetua. How are you doing?
Very well, and you?
I'm wonderful. Thank you.
All right. So talk to us about asthma in children. You know, it's also known as pediatric asthma. Is it different from the one in adults?
I'll say, first of all, pretty much 80% of all asthma starts out in the pediatric age range. So there are just very few that we call adult onset. Generally, I think for the most part, we see the pediatric age range. So it's more, generally we just call it asthma. We don't really like differentiating. It's actually when it starts out in adulthood, the announce is adult onset asthma. And so it's a genetic condition. It's not acquired. So it's not like, okay, you did something and that's what caused it. The environmental factors actually just make it worse. But genetically, the origin is genetic, which means that your airways start from your nostrils all the way down to the little alveoli in your lungs. They are hyperreactive. And hyperreactive in the sense that once they are irritated, they secrete a lot of mucus and they also become constricted or smaller. And so they find it difficult to get in air. And so that's why, when you are close to an asthmatic patient who is having what we call an attack, also call it an exacerbation, what you hear is that difficult sound or that sound of airway trying to force itself into the airway. And that's what we call a wheeze. So, like I said, it's genetic. It's caused by constriction of the airways when they are sensitized.
All right. Talk to us about the signs or the symptoms of pediatric asthma. What are the things that we get to see?
Okay, so it starts out very early, for those who start out normally. So you could have a child who is always having a cough, a catarrh, and it's actually, it's quite all-encompassing. What we see, the asthma we see, it's just the lung effect, or the effect or the sign and symptom in the lung. But you can also have other effects on other systems, like the skin. They could end up having atopic dermatitis, having rashes very easily. They could end up having atopic conjunctivitis, always itching their eyes and stuff like that. So there are some people that are generally termed atopic, which means that their skin or their body is usually very, very hypersensitive. So when it affects the lungs, that's what we call, asthma. And so the first sign you notice at the very early age is that, you have a parent, as a pediatrician, I have a parent who comes to me with their child and says, my child has been having cough and catarrh for the past 3 weeks. This one, that, you complain about frequent cough and catarrh and stuff like that. And that usually progresses. And the thing about the cough and catarrh is that, at times, as the child gets older, maybe 2-3 years, they start noticing that, like you said, there are certain things that trigger it. Maybe if the child, if the weather is very cold, or if the child goes into a dusty environment, or if the mother is frying plantain in the kitchen, or things like that, there are certain things that they begin to notice that causes this difficulty in breathing, and that is usually the first sign, that's the first sign that we start thinking, okay, maybe this child is atopic. And then usually I want to ask, are there other signs? Is the child always itching the eye? Is always having rashes and things like that? And so to a huge extent, the diagnosis is made clinically. By the time I ask a few questions and then trials, there's something we call trial of the medications, like the salbutamol or Ventolin. And if the child now gets some reprieve from that, I can now say that it's very likely that this child is asthmatic.
Oh, wow. I like that you already started talking about diagnosis. But then, seeing that the test may not be able to confirm asthma in children younger than 5 years, how do we go about diagnosing younger children?
Yeah, it's still, the test you're probably talking about is the peak respiratory flow meter, and it's just a very small tube that we ask the child to blow into. There is, for you, for a normal child, if I give you that tube and, you blow into it, I expect a lot of air to push out the gauge to a very far level. But if a child can't do that, then I probably think that this child has some kind of obstruction in the airway. And you need a cooperative child to be able to do that. You need someone who is probably from 6, 7, 8 years of age to be able to do that. Now, for those below, clinical diagnosis is enough. If I ask a few questions, find out that, okay, this child, my mother comes to me and tells me that I've noticed that my child, whenever he's around dust or, he starts having this difficulty in breathing. Usually a difficulty with breathing is not associated with fever, and it's seasonal. It comes and goes. sometimes, there are certain questions I'll ask. Maybe is it worse at night? Usually it's worse at night because your airways actually get smaller at night, and from picking all that information and then saying, okay, fine, let's try out this medication. If you try it out and then, it starts working appropriately, then I can say that this child is asthmatic. So I might not need to do the whole peak expiratory flow rate and other tests that I need to do.
Okay. Well, it's known that some of the symptoms actually require urgent medical attention. You might talking to us about some of these other symptoms that might be very, very serious.
Yeah, so there is what we call exacerbation of the symptoms. Usually, for those who are asthmatic, they can have, once in a while a cough, once in a while they wheeze. But imagine, taking someone who is asthmatic and who is triggered by, say, smoke to a place where they are frying plantain in a room, and then he inhales that smoke. It can be so bad that the airways actually lock up. And, at that point in time, what we advise them, if you've made the diagnosis, they usually should have their inhaler around. So we tell them that, if you start having difficulty in breathing, use your inhaler, take a few puffs, age-dependent puffs. If you are below 6 years, you can take just like 6 puffs. If you are above 6 years, you can take as much as 8 to 12. And if that is not solving the problem, then they have to come to the hospital. Or for some parents, they've become quite used to it. The first step we do in the hospital, which is nebulization, which means that, we take that medication and we'll put it in a machine that creates aerosols that the child now breathes in. Some parents who are rich enough, or not necessarily rich, but who are well enlightened, already have that nebulizing machine in their home. So once the child starts having that situation, they start nebulizing. But if they nebulize, 3 times every 20 minutes for 3 times, and they're still not good enough, then they have to come to the hospital. And at that point, you now start adding other medications, like steroids, other kind of short-acting beta agonists. And well, we keep doing that and it's not working out, we might have to go for IV medications. In the worst case scenario, the child might have to be intubated. Intubation means that we have to take over the respiration. We paralyze the child in quotes and take over the respiration of the child to help the child breathe better. So I usually advise those who have asthmatic children, look, once you've tried this inhaler and it's not working, if you don't have a nebulizer at home, come to the hospital, because the worst case scenario is that lungs, those lungs get completely blocked. And, you can imagine not breathing for 2 minutes. You can imagine what it feels like. That's actually what they're going through. So it's an emergency and it has to be handled very quickly.
Well, that must be a whole lot for a young child. And of course, the caregiver, I can't imagine the stress. I can't imagine the feeling. But now let's talk about the causes, the triggers and risk factors. I think earlier you were saying that to a very large extent, it's genetics. So we may not necessarily say that there is a cause. But of course, there might be some things that we might just probably classify as causes, triggers, and then the risk factors, basically.
Yeah, so like I said, is genetic. For those who it starts out in adulthood, they probably didn't notice, or maybe the phenotype is a very mild phenotype, and then it starts out in adulthood. So the only thing I can say is that, if you have parents who were atopic, then it's most likely that they might pass it on to the child. In fact, some of the gene loci that are responsible for this haven't been fully identified. A lot of studies are still going on to identify them. And until we can start, altering genes, which is a very, very delicate and, controversial thing to do, we can't, do anything about it. But the triggers now, we've mentioned a few already, the weather. Some people get triggered when the weather is very cold. And because usually when you're cold, your vessels, vasoconstrict, they become smaller so that, your blood doesn't go to the skin, it goes, to the inner part of your body. So that's why when you're cold, if you touch someone, the skin is usually very cool because you're redirecting blood from the skin to the inner parts of the body. And that vasoconstriction can also affect, the bronchioles or the airways. And then other things like people have different triggers. For some people, I know someone who is triggered by perfumes. For some people, it could be powder. For some people, it could be dust. Many people dust. For some people, oil and smoke and things like that. So those are mainly the triggers. What we usually advise, for some people, even formats, bed sheets and things like that. So what we usually advise is find out very early what this child's trigger is and start, removing those things from the house. And, if you have a child who's asthmatic, then your house has to be extremely clean. Because like I said, many people, like 50-60%, they are triggered by dust. So you have to make sure that, you don't have aerosols in your house. You have to clean a lot. and make sure you don't stay close to the dusty area. And then, as much as possible, don't do anything that's going to trigger that child, because the more they have it, the more damaging effects it can cause to the lungs.
Okay, I'll take you on what to do to, apart from cleaning the house, what else can you do? Do you need humidifier? That's one. I'll take you on that. But just before we get there, I'd like to know, there is that which is called allergies and there is asthma. Of course, we know what asthma is, but is there any connection between the two?
Yeah, so it's a progression. Every asthmatic child is allergic. Some people luckily stop at just atopy. There are some people who just are atopic. They don't have asthma, but they always, they walk into a dust room and they start having catarrh immediately. They go out at a spectrum, or which starts out at atopy. You probably have atopic rhinitis, atopic conjunctivitis. Rhinitis is the catarrh, conjunctivitis that affects the eyes. Atopic dermatitis, anything that irritates their skin. Then there is the other spectrum airway. They are not fully asthmatic, but they don't need to be around us, because when they're around it, they start coughing and becoming uncomfortable. And then the other extreme is now asthma. And that in itself, it's is one that is more concerning, because those airways can completely become blocked and cause an acute emergency. So it's a spectrum. But like I said, every asthmatic child is allergic. It's not a question of, but not every allergic child is asthmatic. I think that's just the best way to put it.
What are the things we really need to ensure that, children who are already asthmatic do not keep getting attacks over and over again?
Yeah, so in the clinic, the first thing I always advise them is, look, madam, you have to find out what is causing this problem. A huge percentage of them, it's by dust, say 50%, 50 to 60%. But for the others, there are some that have very funny things, funny triggers. Some, for example, cats or dogs or fur. So you have to find out what the trigger is. Most times I advise asthmatic patients not to have pets, because fur and hair is something else that can trigger an asthmatic attack. So the first step in prevention is to find out what this causes. It's something that can take some time anyway. It's not like the mother is just going to go back and all of a sudden she knows what the cause is. It might take a period of about a year. But in the interim, since we already have an idea of what the frequent triggers are, the next thing is to advise them to make sure that generally they remove all the triggers. So make sure that you remove all the dust. Don't use for some people in very poor income areas, they still use firewood to cook. Firewood is a very major trigger, so don't use that. Or if you have to use it, use it outside and far away from the child. Don't fry things when the child is around. Watch your perfume, watch your hair, and things like that. So the major thing is preventing that onset. And then the next thing is now stopping the progression when it starts. So like I said, sometimes they can have, just a very mild attack, nothing serious. The asthma exacerbations are classified into for mild, moderate, severe, and then life-threatening. So sometimes they can just have a mild attack. They just take a few puffs of their inhaler and they continue doing what they are doing. But if you don't take that inhaler, then it's likely to progress to something life-threatening, the other end of the spectrum. So the next thing is always advise them to have their medications around and tutor them on how to use those medications, because there are some people that don't know how to use the medications. It's not just about puffing, it's about taking a deep breath, puffing, and then holding your breath so that the aerosols go in and do their job. And then if it now becomes for those like you said, you identify those below 5 years, it's usually very difficult to handle them. So there's something called a spacer device. It can be bought in the market, and it can also be locally produced. Locally, if you get a very big bottle of Everwater, you can cut off the bottom, and then you can put the inhaler at the opening. That's the what do I call it now? The cap, where the cap is. Put the inhaler there, and then put the part that you cut off around the mouth of the child, and then now put in those puffs. That way the child has no other option but to breathe in that particular air or the aerosols that you put in there. So preventing the triggers and then stopping the progression of the attack, before it gets very, very bad. And I think those are and then, in the long run also, there are some children who have some that are, very frequent, and then we place them on long-term medications. So we have medications like Seretide or steroids that they take long-term, maybe just one puff every day, or one in the morning, one at night. Whether they have an attack or not, they have to take it. So those are the basic steps that we take to ensure that, it doesn't, is prevented or or the life-threatening form is prevented.
All right. I'd like you to talk about the likely complications of pediatric asthma.
Well, the first and most concerning is death. Like I said, the exacerbations are transferred into mild, moderate, severe, and then life-threatening. If that exacerbation is not controlled on time, the airways could become completely blocked up, and no matter, even if you're giving aerosols, you need the airway to be open to be able to accept those aerosols. So in that situation, we have to move from, giving them nebulization or, giving them salbutamol inhaler, and then now go to IVs, use things like IV aminophylline. And then worst case scenarios, we have to intubate them to make sure that they get, the appropriate, that they get their airways open. Then other complications, many times, because it's a spectrum, they end up with, they can end up having, a COPD or, long-term damage to their lungs. Also, there's a lot of affectation. There are studies that have studied the effect of asthma on school performance, because many times they have to be out of school and things like that. So, there is also the psychosocial aspects, which are, complications that we should also consider, especially when they are always out of school, or maybe when they can't relate to their peers, they can't play football because the area is dusty and things like that. So those other aspects are also things that we'll put into consideration. Then if the child is generally atopic, you have things like, skin disorders, when they keep having atopic dermatitis, those are also other complications that could arise from them. But our major concern, obviously, is a situation where, the child gets into the life-threatening exacerbation, which can, lead to death.
Okay, that's a sad one then. But before we close, I'd like you to just share your thoughts, maybe some thoughts for caregivers, parents, who are taking care of these children.
Yeah, so I've counseled quite a few of them. The first thing is to be patient with the child. They need a lot of patience. Well, the problem with asthma is that it's a chronic illness. It's not like malaria, you treat it now and it's gone. So it's a chronic, and whenever I have a chronic illness, the doctors are encouraged to counsel the parents about the long-term, cause of this illness. So the first step is to be patient with them. Have your inhaler by the side. Come for frequent visits. Don't self-medicate. Some people just, once a child has an attack, start giving prednisolone and steroids and things like that. Don't self-medicate. And they are still very smart kids. It's not like it's affecting their brain or anything. It's just a long condition. So give them the best, and don't give up on them. I think you can still bring the best out of them. It's not the end of the world.
Okay. Thank you so much, Dr. Ikechukwu Kongo, consultant pediatrician, University of Nigeria Teaching Hospital, Enugu. Thank you for coming on the show, sir.
Thank you very much. You're welcome.
All right. Well, many thanks for joining me today on Fit and Well. And of course, it's a wrap on the show for today. My name is Perpetua Fasami Peter. See you some other time. Bye for now.